Good morning, students. Today's lecture is on the ketone bodies and its clinical implications. The specific objective of today's lecture is diabetic ketoacidosis and its clinical complications. And the general objective of today's lecture are metabolism of ketone bodies and to understand the biochemical basis of diabetic ketoacidosis. First of all, let us know what are ketone bodies. Ketone bodies are acetone, acetoacetate, and the beta-hydroxybutyric acid. These three are the ketone bodies, and among the three, acetone and acetoacetate, these two are the true ketone bodies, and they contain the ketone bodies in the structures. And this kind of ketone bodies, these are actually the water soluble, and they are transportable form of the acetyl units. Ketone bodies, they are formed in the body in case of starvation and diabetes mellitus. Apart from this, the ketone bodies are formed when the carbohydrate content is less in other clinical conditions, just like the toxemia, pregnancy, sometimes an infection, trauma, as well as some poisoning, methyl and ethanol poisoning as well. In this condition also, the ketone bodies will be formed, and sometimes the ketone bodies are also formed in those subjects who were in ketogenic diet. That diet we also call it as Atkins diet. In that condition, the ketone bodies are also formed. And in starvation and diabetes mellitus, the ketone bodies are generally formed from the oxidation of the fats, because with regard to the starvation and the diabetes, what happens is that the hormone insulin production will be less in case of type 1 diabetes. That's why when there is a high ratio of the glucagon to insulin, that high ratio of the glucagon will activate the hormone sensitive lipase system, and that hormone sensitive lipase will break down the TZ molecule to the free fatty acids and glycerol, and the fate of that free fatty acid and glycerol are the free fatty acid will enter into the circulation. They are carried by the albumin and they are carried up to the liver. This and liver is the main site of ketone bodies production, and the product that is formed in the liver after the transport of that fatty acid is the acetyl CoA units. Okay, that acetyl CoA units are formed by the beta oxidation, which takes place in the mitochondrial matrix of the liver, and that acetyl CoA are the sources of the ketone body biosynthesis during the time of starvation and in uncontrolled diabetes, as well as in low carbohydrate diet taken conditions. And the main purpose of the ketone bodies in our body is that they can be utilized by the extra hepatic tissues like the heart, the brain, renal cortex, as well as cardiac and skeletal muscles for the fuel source. If we see the general plasma concentrations of fatty acids and ketone bodies in different nutritional states, uh, the acetoacetate in normal plasma concentration is less than 0.1 millimole per liter. Similarly, in fasting condition, it is 0.2 millimole per liter, whereas in case of starvation, it is 1 to 2 millimole per liter. Similarly, the concentration of the beta hydroxy also varies according to the nutritional status. And in normal status, it is less than 0.1 millimole per liter. Similarly, in fasting condition, it is 1 millimole per liter, and in starvation, it is 5 to 10 millimole per liter. These are the some of the conditions of the concentrations of the ketone bodies in case of starvation. And generally, the ketone bodies in our body will start to form after 2 to 3 days of fasting. The general sources of the ketone bodies are due to the high availability of acetyl-CoA, actually, which are formed from the breakdown of the fatty acid molecules. In case of starvation, because that time the hormone glucagon level will be more, and that glucagon will activate the hormone sensitive lipase that brings about the high availability of acetyl-CoA in the liver cells, and so that the liver cells are highly flooded with the acetyl-CoA in that time, and later on that acetyl-CoA will be channeled towards the formation of the ketogenesis, whereas the TCA cycle and the fatty acid biosynthesis will be retarded in this condition, because at that time one of the important intermediate of the TCA cycle, that is oxaloacetic acid, that will be diverted towards the formation of the gluconeogenesis, so that intermediate of the TCA cycle will be lacking, so that TCA cycle cannot continue. Furthermore, the fatty acid synthesis can be taken place, because this fatty acid synthesis will be taking place only in case of high feeding state condition. But here the fatty acids are being mobilized, and the condition is starvation, so that the fatty acid biosynthesis system also will be retarded, and that's why the excess acetyl-CoA they are channeled towards the ketone body synthesis. And after the formation of that kind of ketone bodies in the liver, uh, from the liver they are synthesized, and after the synthesis, that ketone bodies, these are the water soluble substances, so they do not need any extra carrier molecule for their incorporation into the circulation, so that they freely move from the liver to the and come to the blood, and when they come to the blood, they are uptaken by the extra hepatic tissues like the brain, uh, heart, as well as skeletal and cardiac muscles. But this kind of ketone bodies, they cannot be utilized as a fuel source for the tissues like the red blood cells as well. And sometimes the brain also switches to using predominantly acetoacetate in starvation as well as in diabetes. In these conditions, the brain can utilize as a sole source of energy in high conditions of starvation as a ketone bodies as a fuel. Now let us see the process of the biosynthesis of the ketone bodies. We simply call this process as the ketogenesis, and the main source for the ketogenesis is the acetyl-CoA, and that acetyl-CoA will be formed from the beta oxidation of the fatty acids in the liver cells, and this process will take place in the liver cells when the liver cells are highly flooded with the acetyl-CoA by means of the oxidation of the fatty acids. And in this process, what happens is that first the acetyl-CoA, 2 moles of acetyl-CoA will combine in the presence of the enzyme thiolase, which is the enzyme they are present in the reversal of the final step of beta oxidation to form acetyl-CoA. Later on, this acetyl-CoA will be acted by next enzyme, that HMG-CoA synthase, with the addition of one more acetyl-CoA units to the acetyl-CoA, forming 3-hydroxy 3-methylbutyryl-CoA, and this SMG-CoA synthase is the regulatory enzyme of this metabolic pathway. After the formation of the HMG-CoA lyase, this HMG-CoA lyase, will cleave the 3-hydroxy 3-methylbutyryl-CoA to the acetoacetate, and now from this acetoacetate, these two ketone bodies will be generated. They are the acetone as well as beta hydroxybutyric acid. The spontaneous decarbonylation of the acetoacetate, it leads to the formation of the acetone, and this acetone is an organic ketone bodies, and it is a volatile substance, and when it is exhaled through the lungs, it gives fruity smell to the breath. And when this acetoacetate will get reduced by means of the enzyme beta hydroxybutyric dehydrogenase, utilizing NADs, that acetoacetate will be converted to the beta hydroxybutyric acid, and these two acetone and beta hydroxybutyric acid are being derived from the acetoacetate. That's why acetone as well as beta hydroxybutyric acid, sometimes we also call them as the secondary ketone bodies, whereas this acetoacetate we call it as the primary ketone bodies. And the synthesis of these ketone bodies especially takes place in the liver cells, but liver it does not utilize ketone bodies, because for the utilization of these ketone bodies it needs an extra enzyme, that the thiophorase. That thiophorase enzyme will be absent in the liver cells. Now let us see the degradation of the ketone bodies. Uh, the degradation of the ketone bodies will take place during the time of the starvation, in case of uncontrolled diabetes, and in case of low carbohydrate diets. And especially the purpose of the degradation of the ketone bodies is to provide energy to the brain cells, renal cortex, and skeletal muscles and cardiac muscles, which are the extrahepatic tissues during the time of the starvation. And here, the beta hydroxybutyric acid will be acted by the beta hydroxybutyric dehydrogenase, and it will form acetoacetate. And after the formation of the acetoacetate, that acetoacetate will be acted by an enzyme known as succinyl-CoA acetoacetate CoA transferase. This enzyme, sometimes we also call it as a thiophorase, and it converts the succinyl-CoA to the succinate, and finally the coenzyme A will be transferred to the acetoacetate, forming the acetoacetyl-CoA, and later on that acetoacetyl-CoA will be acted by the thiolase, and it gives rise to the two modes of the acetyl-CoA. Now this acetyl-CoA will enter into the Krebs cycle in the extrahepatic tissues for the generation of the ATP molecules. And from this acetoacetate molecule, generally 19 moles of ATP would be produced, whereas from the hydroxybutyric acid, especially 21.5 mole of ATP will be produced during the degradation of the ketone bodies. And the degradation of the ketone bodies will be taking place in the extrahepatic tissues. Now let us see the regulations of the ketone bodies. Actually, the regulation of the ketone bodies will take place on behalf of hormonal regulation, and sometimes the regulation of the ketone bodies are also dependent on the availability of the fatty acids, the entry of the fatty acid into the mitochondrial matrix, and the channelization of the acetyl-CoA into the ketogenesis as well. Now let us see how the ketone bodies are being formed, how they are regulated actually. In case of conditions just like the starvation, actually the counter-regulated hormone of the insulin is very high. That's why the glucagon will activate the hormone-sensitive lipase of the adipocytes, converting the free triacylglycerol to the free fatty acids. Now these free fatty acids will move to the circulation, and from the circulation it is uptaken by the liver cells. In the liver cells, that free fatty acid by means of the beta oxidation convert to the acyl-CoA, and finally after the formation of the acyl-CoA, this will be carried to the mitochondrial matrix by means of the transport system, that is the carnitine transport system, and that after the uptake of that acyl-CoA, that is activated acyl-CoA into the mitochondrial matrix by the carnitine transport system, it will, that acetyl-CoA will follow the pathway of the beta oxidation, and finally it will give rise to FADs to NADs and the acetyl-CoA molecule, and that acetyl-CoA molecule are channeled for the formation of the ketone body. And especially this is for the production of the fuel source during the time of starvation to the extrahepatic tissues, and the glucagon will promote the synthesis of the ketone bodies as well. And in general, what the phenomena will be going is that the glucagon will activate the adenylyl cyclase system, converting ATP to the cyclic AMP. Then it will activate the protein kinase inactive to the protein kinase active, and especially the protein kinase is the A. Protein kinase A will become activated, and that protein kinase A will the inactive hormone sensitive lipase by the process of phosphorylation. That's why the phosphorylated hormone sensitive lipase will form, and it will convert the TZ molecule to the free fatty acids and the glycerol, and that glycerol will move in the part for the gluconeogenesis, whereas the free fatty acids will transfer to the liver for the beta oxidation, generating acetyl-CoA for the biosynthesis of the ketone bodies. And next important phase of the regulation of the ketone bodies is due to the availability of the fatty acids. That during the time of starvation, there will be more of the availability of the fatty acids will be there due to the high amount of the hormone glucagon. That's why at that time it will increase the biosynthesis process of the ketone bodies. And after the formation of the fatty acids, okay, they get entry of the fatty acid into the mitochondrial matrix, because during that time one of the important regulator of the fatty acid inside the mitochondria is the carnitine acyl transport system, that the substrate, the manoline CoA, which is the product of the fatty acid synthesis, will be low at that time. That's why the inhibition of the manoline CoA to that carnitine acyl transport system will decrease, so that that carnitine acyl transport system will be active, and furthermore it leads to the uptake of the fatty acids inside the mitochondrial matrix for the generation of the ketone bodies. Of course, next is the channelization of the acetyl-CoA into the ketogenesis, because uh, due to the intermediates of the TCA cycle, just like the oxaloacetic acid, they are diverted, being mailed for the formation of the gluconeogenesis, so that ketone bodies cannot uh, so that during that time that TCA cycle cannot be proceed, and furthermore due to the beta oxidation process, the ratio of the NADH and NAD plus will be more. Okay, that's why that high ratio of the NADH and NAD plus will also inhibit the enzyme of the TCA cycle, that is the isosaccharic dehydrogenase, and that also leads to the halt of the TCA cycle, so that acetyl-CoA will be channeled towards the formation of the ketogenesis in case of starvation and uncontrolled type 1 diabetes, with regard to the low carbohydrate diet as well. And of course, with regard to the effect of the hormones, the insulin will be low in case of diabetic ketoacidosis. That's why at that time high glucagon will be there, and condition is starvation. That's why ultimately that glucagon will favor the beta oxidation process, and finally it leads to the formation of the ketone bodies. This is all about the regulation of the ketone bodies. And furthermore, if we look at a short glimpse of the hormonal action of that, decreasing the insulin and increasing the glucagon will increase the lipolysis process, and that lipolysis will increase the free fatty acid in the plasma, so that it increases the hepatic output of the ketone bodies, and finally it leads to the ketoacidosis. And the ketoacidosis, especially, it is formed by the high concentration of the beta-hydroxy acid in case of starvation and the diabetes mellitus, especially it is the type 1 diabetes, and that is if it is uncontrolled one diabetes type 1. Now let us see the today's specific objective of today's lecture, and that is diabetic ketoacidosis and its biochemical consequences, and especially what is the diabetic ketoacidosis. Especially the diabetic ketoacidosis, it is a medical emergency situation, and this diabetic ketoacidosis is a triad of hyperglycemia followed by ketonemia followed by metabolic acidosis. That's why it is a medical emergency situation, and in which condition the diabetic ketoacidosis is favored is that in case of uncontrolled type 1 diabetes and in case of starvation. And the special reason for the diabetic ketoacidosis is due to the production of the high production of the ketone bodies, that is the beta-hydroxybutyrate acid. It is the main cause of metabolic acidosis in uncontrolled type 1 diabetes. And the generation of the ketone bodies in case of diabetic ketoacidosis is is the same mechanism, just like we had talked earlier. That is the due to the starvation and uncontrolled diabetes, what happens? The more of the fatty acids will be mobilized, and by means of the increase in the counteracting hormone of the insulin glucagon, and that will activate the hormone sensitive lipase, increasing more of the free fatty acids, so that that free fatty acid will be moving to the circulation, and from here it will be coming to the liver cells, and the liver cells more scalp will be formed, and at that time more ketone bodies will be synthesized. Similarly, the TCA cycle will be halted because the more of the oxaloacetic acid, they will be diabetic towards the formation of the glucose that time. And in which condition the diabetic ketoacidosis will result when the insulin is absent? Actually, what happens is that in normal metabolism, what happens is that the production of the ketone bodies and their utilization are being balanced. But when there is a low insulin is there at that time, uh, the glucagons and the counteracting hormones, just like the glucagon, corticosteroids, growth hormone, and cortisol, they become high, and all that will favor for the oxidation of the fatty acids, and that oxidation of the fatty acids will lead to the high production of the ketone bodies. And when the concentration of that kind of ketone bodies, uh, when the concentration of that kind of ketone bodies will increase, uh, will increase, it leads to the ketonemia. And the ketonemia is especially due to overproduction of the ketone bodies and its underuse. And the normal serum concentration of the ketone bodies is around 1 to 3 milligram per deciliter. But in case of diabetic ketoacidosis, that concentration can reach up to the 90 milligram per deciliter in the blood. And similarly, the urinary concentration of the ketone bodies will also increase, and that increase urinary concentration, we call it as a ketonuria, and the ketonuria at that time will be greater than 5,000 milligram per 24-hour urine, and especially the ketone bodies, they are excreted in the urine on the acetone and the acetoacetate, and the acetone and the acetoacetate can be detected by means of the Rotra test in case of ketonuria. The ketonemia followed by the ketonuria, we call this clinical process as a ketosis, because here in ketosis, both the ketone bodies will increase in the blood as well as the urine concentration of the ketone bodies will be increased. That is the ketonuria. The combination of the both ketonemia and ketonuria, we call it as a ketosis. And during the process of the ketosis, what happens is that there will be a smell of acetone coming in the breath, and that smell of the acetone is a fruity color, and especially that acetone is a volatile substance. And this both acetoacetic acid and beta-hydroxybutyric acid are acidic. That's why if the level of these ketone bodies are too high, the pH of the blood will drop, and it will lead to the metabolic acidosis. And other important features of the diabetic ketoacidosis are it can also lead to the osmotic diuresis if the concentration of the both glucose and the diabetes, both glucose and the ketone bodies will be increased in the blood, then it leads to the osmotic diuresis, and that result of that osmotic diuresis are they will lead to the high loss of the electrolytes along with them, and that kind of glucose and the ketone bodies, they will be lost in the urine, and it will decrease the blood volume as well, and also it can lead to the dehydration. That's why the main features in case of diabetic ketoacidosis are the triad, which consists of the metabolic acidosis, hyperglycemia, and the ketonemia, where acidosis it leads to the decrease in the concentration of the pH to less than 7.3. Of course, when the concentration of the pH will be increased, then the pH will be buffered by the bicarbonate buffer system present in our blood, and that's why the concentration of the bicarbonate will be decreased. And when the concentration of the bicarbonate will be decreased, it leads to the high anion gap metabolic acidosis that time. and hyperglycemia in the blood will increase by means of 250 mg per deciliter. Similarly, there will be the ketonemia, positive ketones in the serum or in the urine. But this kind of ketoacidosis process can take place with regard to the type 2 diabetes, because the conditions of happening in type 2 diabetes is that okay, there is a less amount of insulin are there uh, in the patients with the type 2 diabetes. That's why that insulin will prevent the ketogenesis, ketoacidosis in case of type 2 diabetes. So if you see some of the metabolic and the clinical abnormalities in the TKA, especially with regard to the counter-regulatory hormones production, with the high production of the glucagon as compared to the insulin, and following are the biochemical changes in case of diabetic ketoacidosis. For example, in the carbohydrate metabolism, there will be the increased glycogenolysis and the increased glucogenolysis. That's why the whatever the glycogen stores are there in the body, the glycogen stores will be exhausted within 24 hours. And after the exhaustion of the glycogen stores, then it leads to the degradation of the fatty acids, and finally the ketone bodies will be formed that time. And this high gluconeogenesis or glycogenolysis, of course, it will lead to the increased liver glucose output, and it leads to the hyperglycemia. When there is hyperglycemia, it also leads to the increase in the plasma osmolality. Especially the plasma osmolality is around 290 milliosmoles per kg. But in case of diabetic ketoacidosis type 1, generally the plasma osmolality is just greater than 290 milliosmoles per kg. But with regard to the type 2 diabetes, the plasma osmolality will be greater than 320 milliosmoles per kg. And this increase in the plasma osmolality in case of diabetic ketoacidosis is the cause of the osmotic diuresis as well as the dehydration. Because due to the osmotic diuresis, there will be the loss of the electrolytes like the sodium and potassium. Along with the sodium and potassium, the magnesium chloride and phosphate will also be lost in the urine, so that the level of sodium will also decrease in case of diabetic ketoacidosis, and it leads to the hypovolemia, and it leads to the dehydration. And furthermore, high production of the beta hydroxybutyric acid also decreases the pH of the blood, and the uh, pK of the carboxyl groups present in the beta hydroxybutyric acid is around 4, so that in dehydration, in that pH, more of the hydrogen will be dissociated from the beta hydroxybutyric acid, and that's all. So what happens in this is that the dehydration, that is the low plasma volume followed by high level of the plasma hydrogen ion concentration, will further increase the severity of the metabolic acidosis in case of diabetic ketoacidosis. And when there is high concentration of hydrogen ions in the plasma, that high concentration of the hydrogen ions in the plasma will lead to the increase in the level of the potassium in the blood, because due to that high concentration of hydrogen ions in the plasma, that hydrogen ion will be shifted inside the ICF, and from the ICF, potassium will be shifted to the ECF to maintain the electrical neutrality in the cell, and the product of that is the rise in the level of the serum potassium as well, which is the main cause of hyperkalemia in case of uncontrolled type 1 diabetes. Furthermore, the level of the insulin will also decrease. That's why when there is a low level of the insulin is there, the main function of the insulin is to uptake the glucose as well as the potassium. Due to the low insulin, that potassium cannot be uptaken inside the cells, and furthermore, it leads to the hyperkalemia as well. And similarly, with regard to the protein metabolism, there will be increased proteolysis due to the counter-regulatory hormones, and it leads to the increase in the plasma amino acids, and ultimately the product of this plasma amino acids is the formation of the increase in the formation of the urea synthesis. That's why it leads to the pre-renal uremia, followed by uremia, followed by decrease in the GFR. The decrease in the GFR is due to the osmotic diuresis. The plasma volume will also decrease, and Plasma volume decreased along with dehydration leads to the low GFR, and that will lead to the uremia in case of diabetic ketoacidosis. And with regard to the fatty acid metabolism, it will increase the lipolysis, the glycogen, it will increase the lipolysis activity so that it will lead to the increased plasma free fatty acids. That's why it leads to the more formation of the ketone bodies that is followed by acidosis. When that acidosis in case of ketone bodies is the metabolic acidosis. That's why when there is a metabolic acidosis, the compensating effect is the hyperventilation, that H plus ion will bind to the bicarbonate forming S2 and CO2, and CO2 will be exhaled out, and that leads to hyperventilation. And that kind of hyperventilation, we call it as Kussmaul's breathing. It's deep and rapid in case of diabetic ketoacidosis. And with regard to the increased ketogenesis, that increase in the ketogenesis would lead to the ketonemia, and that ketonemia will also lead to the vomiting, because when there is high amount of ketone bodies, it will activate the chemo trigger zone in the midbrain of the medulla oblongata, which stimulates the emetic sensual region, and finally that leads to the vomiting in case of uh, ketogenesis. And apart from this, due to the acetone production in the uh, diabetic ketoacidosis and in starvation, that acetone is a volatile substance, and that acetone will be exhaled through the lungs, and the smell of the acetone that time is protein. Or these are some of the biochemical changes that occurs in case of diabetic ketoacidosis. Especially if we just recapitulate some of the important points in the diabetic ketoacidosis are the level of the PS will decrease to less than 7.3. The blood glucose will increase by greater than 250 mg per deciliter. And finally, the ketonemia, the ketone bodies are here in the uh, blood as well as in the urine, and it is the beta-hydroxybutyric acid that increases the level of the acidity, or it brings the acidotic condition in case of diabetic ketoacidosis. And furthermore, there will be the electrolyte disturbances because of the osmotic diuresis activity of the ketone bodies, as well as hyperglycemia condition that is prevailing in the diabetic ketoacidosis type 1. And for the diagnosis of the diabetic ketoacidosis, the diagnosis of the DKA is usually suspected from the history and the presence of the hyperglycemia with high NINDA metabolic acidosis, and which have a history of polydipsia, polyuria, and may have abdominal pain or vomiting. And the clinical features are the acidotic respiration, the dehydration, and the confirmation of the diagnosis requires the demonstration of the hyperglycemia plus ketonemia or ketonuria, and especially the ketonemia that is being usually considered for the diagnosis the beta-hydroxybutyric acid level in serum rather than acetoacetate and the acetone, because sometimes the urinary ketones also gives to the false positive test as well and false negative test as well with regard to the Rothera test. Okay, now let's see the clinical vignettes for the today's lecture. A 22-year-old patient with diabetes comes to the accident and emergency department. She gives the 2 days history of vomiting and abdominal pain. She is drowsy and her breathing is deep and rapid. There is a distinctive smell from her breath. What is the most likely diagnosis? Which bedside test would you do to help you to confirm the diagnosis? And which laboratory test would you request? Okay, of course, okay, if you see the clinical case here, okay, she has a history of vomiting and abdominal pain, and she is having a diabetes, she is having a deep breathing, and the smell is coming from her breath. Of course, all these clinical scenario will indicate the most diagnosis is the diabetic ketoacidosis. And which bedside test would you do to help you to confirm the diagnosis. Of course, the bedside test we are going to do for this subject are it is due to the diabetic ketoacidosis. We have to go for the blood sugar level, as well as the other test we could do is the electrolyte imbalance will be there, and that electrolyte imbalances. Among that, we have to see the level of the sodium, the potassium, as well as other electrolytes. And apart from this, we also have to do the blood test for the beta hydroxybutyric acid to confirm the disease as well. And which laboratory test would you request? Generally, the laboratory test we request for this subject is the blood sugar level as well as the level of the beta hydroxybutyric acid. And also in this case, the sputum will be sent to the microbiology laboratory in case the infection is there, and if that the source of infection, if the source of diabetic ketoacidosis is the infections and trauma as well. That's why this is the uh, overall conclusion for this clinical vignette. And let's see the another clinical vignette. A 14-year-old boy was found by his mother in a drowsy and uncooperative state. When the GP arrived, she told her that her son had seemed to be unusually thirsty for the last 1 2 months, and she thought that he had lost weight. Recently, he had been complaining of the abdominal pain and the discomfort. He was admitted to the hospital as an emergency. On examination, he was semi-conscious with deep sighing respiration, a pulse rate of 120 per minute, a blood pressure of 94 to 56 mmHg, and cold extremities. Chemical investigations on the blood after the admission showed the following results. Just like the urea, it is 24.5, sodium it is 128 millimole per liter, potassium 6.9, glucose it is 35.2, and with the result of the blood gas analysis, hydrogen ion is 82 millimole nanomole per liter, partial pressure of carbon dioxide is 2.5 kilopascal, bithylamide is 7, uh, and similar the partial pressure of oxygen it is around 14. That's why, what is the problem of diagnosis, and how would you confirm this quickly? Because as we have seen from the investigation clinical vignette, here there was a deep silent respiration and the pulse rate is high and there is hypotension, there is a tachycardia, especially there is because the blood pressure is 94 to 56 mm of Hg with the cold extremities. These are all the features they are associated with the diabetic ketoacidosis. And for the confirmation of that diabetic ketoacidosis, if we look at the clinical investigation, just like the glucose level is extremely high because it is 35 millimole per liter. Similarly, there is hyperkalemia, which is associated with the metabolic acidosis. The sodium level is low because due to the osmotic diuresis caused by the high level of the ketone bodies as well as glucose. Hyperglycemia, the sodium level is decreased. Similarly, due to the dehydration, it also leads to the uremia condition, increasing the level of the urea at that time. And due to the production of the beta hydroxybutyric acid, okay, the hydrogen ion concentration is extremely increased, that is the 82 nanomole per liter, followed by hyperventilation during this metabolic acidosis, and it leads to the low concentration of the partial pressure of the carbon dioxide, and followed by due to the high concentration of hydrogen ion, it will be uh, buffered by the bicarbonate buffer system, so that the bicarbonate buffer system will be decreased. And similarly, there was no effect on the partial pressure of the oxygen. It is around 14. That's why all these clinical investigations show that high level of the potassium along with the glucose along with hydrogen ions, it leads to the metabolic acidosis with a high anion gap. And the probable diagnosis for this is the diabetic ketoacidosis. Here are some comments for you in case, okay, if there are any, if there is not proper understanding, please you can go through these comments as well. And then let us see the brief summary of the today's lecture. The primary pathways of catabolism of fatty acids are process known as beta oxidation. It leads to the production of the acetyl-CoA. In the liver, acetyl-CoA is catabolized to the ketone bodies, primarily acetoacetate and butyrate by a mitochondrial pathway termed the ketogenesis. The ketone bodies are exported from the liver for energy metabolism in the peripheral tissue, and ketonemia and ketonuria develop in case of starvation as well as in type 1 uncontrolled diabetes, and this leads to the different clinical complications like the hyperkalemia and the high anemia of metabolic acidosis. Okay, this concludes the lecture for today. I hope you understand the lecture, and if you have any queries, this is the time for queries. You just go through the chapters, and if there is any difficulty for you in understanding, please you can visit me anytime. Okay, thanks to all of you for your nice attention. Okay, have a good day. Take care.